Me giving a talk on ECMO in front of Dr. Bartlett and Dr. Conrad is like analyzing your golf swing in front of Jack Nicklaus and Tiger Woods. So anything I say right now will probably, be disproved at some point. But what we're trying to do is really get, particularly in the perfusionist world, we need to rediscover what we're doing because ECMO has become so prevalent and so out there anymore, and everybody, including Santa Claus, wants to do ECMO now. And maybe they shouldn't, but that's where we have to, I think, try to define ourselves in the perfusion community. And one of the things we want to do at the Shark Tank tonight is really kind of get everyone's opinion on where do we go and what do we do. And we'll do it in a very informal way. It'll be with beer and pizza. What's better than that? Around a pool in Sanibel. And just talk about, really where do we go from here and where is the profession going in relation to ECMO? Because, again, ECMO is becoming a big part of extracorporeal therapies everywhere. And as I'm going to show you here, it's only going to grow. In mechanical ventilation, and I have a bias, and my bias is that mechanical ventilation should go away. That mechanical ventilation is the iron lung of the 1930s and 40s. That it is going to go away, and extracorporeal therapy is going to replace that. And I believe that because, I don't know if y'all were here last year, but I professed, we don't get airway gases, we get blood gases. We don't get airway PO2s, we get saturations. Why? Because we're measuring the blood. Why are we measuring the blood? Because that's what counts. That's what matters. And so what we do in ECMO is we're manipulating the blood. Why are we manipulating the lungs to make the blood better when we can just manipulate the blood itself? And so that's kind of my bias and where we're going, and I think that's where our future as perfusionists is going. I'm not a perfusionist, but I adopted y'all, or y'all adopted me, but I'll claim to be one, only because I too do ECMO and have done for a long time, which means I like to see a lot of blood outside of the body. To me, it makes me happy, and it makes me understand more and more what I'm doing. The more and more I use a ventilator, the less and less confident I am in what I'm doing. But the biggest call that I get from any center is what do I do with the ventilator? So I put them on ECMO, but what do I do? How do I care for the patient otherwise? And one of the things that we're trying to learn now is what do I do with the ventilator once they're on ECMO? Because they really don't need the ventilator. We kind of have it, but what do you do with it? And so that's kind of what I wanted to go into. And so you go through all of this trouble and you get them and you bring them into your center. Oops. But then what do you do once they're on? What is your advice to the physician? What is your advice to the caregivers? What do I do with the ventilator? And what is the data? Well, unfortunately, there isn't good data. The only thing that we really have is consensus data, which is that we get a bunch of people together in a room and we all decide what's good. Is that bad data? It's really not, because it's really what we call best practices, which is you do something for so long and you do it the best way that you know how, and you get good outcomes. That's actually a pretty good trial, and sometimes that's the best we can do. If you look at the pediatrics population, almost all of the pediatric care that we do is best practices. There's not randomized controlled trial. If you look at meningitis, there's not a randomized controlled trial that Rocephin is good. But what do? It's Rocephin. Why? Because best practices have shown that that cures most of them over time, and we've come to accept that as good data. So it's not bad data. We just have to look at it a little differently and say, it's the best we can do, and therefore let's take experts, get them in a room, and figure out what can happen. The other thing we have is survey data. What's everyone doing? I mean, what are they doing across the world? And if everyone's doing it badly, that's one thing, but probably not. Probably everyone's kind of fine-tuned it a little bit, at least to their own practice. So why not a randomized control trial? Why can't we do that? Why can't we say, let's put everyone on ECMO, and then let's do a randomized control trial and decide where, let's decide this mode and that mode. The problem is you can't do it because of numbers. It would take 10,000, 15,000 patients to do it. No one's going to pay for it. And the other thing is the fidelity to try to get down to fine-tuning these kind of, intricacies are probably impossible and probably wouldn't come out with good data, and if it did, it'd probably be disproved in 6 months or a year. So what we're left with is some consensus data and really what we call really survey data, and just kind of see what everyone else is doing and try to mimic that. So if you look at and this was done just a few years ago, almost all centers preferred controlled ventilation. So you put them on ECMO, they're paralyzed, you keep them paralyzed, you put them on controlled ventilation. About 14% favored assisted or spontaneous ventilation. Our center, we do awake spontaneous ventilation. We do not do controlled ventilation after they're 24 hours. Again, that's my bias, but this is what the world's doing. This is a young lady that came in with severe respiratory failure. She had a CO2 of 120. We put her on an extracorporeal CO2 removal device and did not intubate her. As you can see, there's a ventilator right here, but you can see it's on standby. And what we did is put her on low oxygen, put her on this, and I don't know if you can see it right here, but here she suctions herself, she eats, she talks to her family. No ventilator is required. And the reason we're doing that is because we are negative breathers. We were put on this earth to suck in oxygen, not to have a tube put in past our vocal cords that bypasses every defense mechanism we have and air to be blown in. Our lungs are not engineered for that. Our immune system is not engineered for that, but that's what we do, and that's what we've done for 50 years. And what we've shown is almost every mode of ventilation that we've ever conceived has been harmful. If we give oxygen to the lung, we evolved from a low oxygen to 21%. We have no capacity to store oxygen. We store everything else, right? Carbohydrates, glucose, proteins, we store everything. You can't store oxygen. But what do we need? You get a stroke, you need oxygen. But we don't store it. The reason you don't store it is because it's harmful. And one of the things we're finding out in the lungs, if I give her too much oxygen, then neutrophils start going into the lung. The neutrophils start breaking down and they release adenosine. Adenosine goes to the adenosine, supposed to go to the adenosine 2 receptor. What's interesting about that is that adenosine 2 receptor then turns off all of the future recruitment of neutrophils. What do you think oxygen does? It blocks the A2A receptor. So all this, we used to talk about oxygen toxicity, and it was always free radicals and superoxides. It's actually the A2A receptor, and that you don't stop neutrophil recruitment. The other thing we've found is if I put them on a rate's bad. We know volume's bad. We've known volume's bad for 20 years now. Now we find out it's not the volume, it's the driving pressure all of which is we're blowing air into a lung that should receive air. And so we've generated harm this entire time. This is a young man. As you can see him, he is on ECMO. He's only on this oxygen nasal cannula because the nurses couldn't stand not having something in the nose. But ran his entire ECMO with never being on a ventilator. Came in with a PO2 of 20, CO2 in the 90s. We put him on extracorporeal support, and you know what he did here, and I don't know if this will play. It's actually a move. He wants a biscuit, and this is him getting a biscuit. And the reason is because we feel the ventilator is more harmful than extracorporeal support. What's been the norm? We need the extracorporeal support, keep on a ventilator. Let's get them off extracorporeal support as soon as we can because that's what's harmful. What I'm trying to sell is that that's the exact opposite. And that mechanical ventilation is what's harmful. And this is why perfusionists are going to become more and more and more and more important in the ICU care, because we're going to start putting more and more pressure on extracorporeal support because the ventilator is so bad. That's good. And that's on full ECMO support. Dr. Conrad actually put this child on. We know that during ECMO, that most centers put them on low volumes, and they run anywhere from 2 to 6 kilos, but no one has a plan. No one knows what the right number is. And we're going to tell you what the consensus has shown, but right now you can just see, just based on what everyone does, it's all over the map. Positive, some people do best practices. They'll put them on the best PEEP trial, which is you turn up the PEEP, see what their oxygen does. When it levels off, you stop. Some people use the ARDS network table, about 36%. Very, very few use pressure volume curves or anything else. It's probably more physiologic. So you know what we're doing? Taking a guess. I'll put them on this. I'll see what the tables show. What does the table show? Table is based on 1,200 patients. And we have 200,000 patients in ARDS a year. And we're basing almost all of this data on 1,200 to 1,400 patients. So it doesn't make good biologic sense the way that we've mechanically ventilated for a long, long time. About 14% use inverse I ratios. A lot of people use 135-degree proning. You just kind of lay them on their side. About a third use full proning if you need to. And Dr. Conrad will talk about this later, about when the flow runs out. And a bunch use axial rotation during ECMO, but again, it's all over the place. If you look at how many places actually have protocols, it's actually only 18%. So everyone is just kind of doing their own thing. So to give you good information about how to mechanically ventilate someone on ECMO, it becomes very difficult. And so again, we can't depend on what everyone's saying. We just got to get a bunch of people together and hopefully we'll make something up. Early tracheostomy is performed about 65%. And it's funny that 40% do it in the first 4 days. In our institution, we don't. We wait. Some people we do early, some people we do late, but I think that's becoming the way of the dodo bird right now. Mechanical ventilation frequently altered, and I don't know why this worked out so weird, but almost all centers wean VA ECMO or VV ECMO before they wean the mechanical ventilator. And what we're trying to promote is maybe we need to relook at that. and keep the extracorporeal support going and wean the ventilator. Because what's the most harmful? Far more harmful, day after day after day, study after study after study, is mechanical ventilator, not the extracorporeal support. But we've always looked at it differently. We've always looked at it as mechanical ventilator is the savior and extracorporeal support is the salvage. What I'm trying to sell is, let's think of it opposite and think of extracorporeal support as the wave of the future in mechanical ventilation is only if it's necessary. This is a very interesting study. This is out of Denver, and they had a ventilator protocol. And they looked at the ventilator pre and post, and they came up with these great numbers. If you put them on a ventilator and you adjusted it, you got these great numbers. You look at this, shorter stay, all of this. The problem is the last sentence of the study is only 20% ever followed the protocol. They only studied the 20% that followed the protocol. 80% never followed the protocol. So again, the mechanical ventilator, I think, has become much more of an enemy than a friend, much more of a foe than a friend. But if you're going to have them on mechanical ventilation, and we do, this is the best consensus. And if there's only one slide I can give you, this is what is best. And this was a consensus conference between actually the European and the United States, about 30 people in this conference call. And we came up with decide spontaneous or controlled, but if it's spontaneous, pressure support of 10 to 12, a PEEP of 10, and look at this, FiO2 30 or less. Why? The A2A receptor. Oxygen is horribly, horribly harmful to the lung. Ain't that weird? I mean, it just feels bad, right? But we know it is. 21% is great. 30% is probably okay. 40%, 50%, 60% becomes harmful, and all because of that A2A receptor. If you do controlled ventilation, probably a pressure controlled so that you can control driving pressure, and we look at lower PEEPs, probably PEEPs 10 or less, FiO2 of 30%, but certainly driving pressures of less than 14. And this is the best consensus conference out there. And this is like 3 months old. So it's very new. This is the way that you should ventilate. But what does this do? It puts more and more burden on extracorporeal support, which brings you in because you have to be that best advocate of that extracorporeal support and be the ones that champion. Extracorporeal support is safe. It's not harmful, it's safe. So our institution, we use controlled ventilation very early, just getting them on, get them spontaneously breathing as quick as possible, and then extubate them as quick as possible. And extubate them on extracorporeal support. We wean the ventilator first and the ECMO second. And I think that's really the wave of the future. Here's another child, again, asthmatic, on oxygen because we had to put something on the kid. It just felt bad not to because we're so used to it. Didn't need it. Had a CO2 of 160 on admission. This is some 20 hours later, and this is just sedated because we decannulated, we wanted the kid calm. But 2 hours later, the kid is drinking. 8 hours later, eating a McDonald's hamburger. Try that on a ventilator. That kid would have been, weeks probably getting off the drugs we'd have to give this kid. Now, one thing that Dr. Conrad will remind me of is this kid cussed out the nurses several times, and we should have intubated him just to shut his mouth, but we didn't. We were kind, but we should have, because he actually asked where his hamburger was, bitch. Now that's 5 years old. Now my mom would have put me back here, or probably back on ECMO. But the example is we use ECMO as our primary support system and the ventilator second. And that is really, I think, where the world is going. And again, as a perfusionist community, that's going to put more and more burden on you, which I don't think is a bad thing, because you are the experts on extracorporeal support. But we have to get away from this mentality that the ventilator is the salvage. I mean, the support, and ECMO is the salvage, and start thinking the other way. And I think that that's where we are in our future, and I think this is how I think perfusion is going to actually explode in the next couple of years because of this change in philosophy among intensivists and people that do critical care and deal with ECMO. Pretty short, but I caught up on time.
Each year I have the privilege of basically handing out an award for someone that has guided what I consider this meeting a large sailing vessel. It's a ship that, you know, we have to have leaders that guide us and basically expand this meeting to another level to get us to our destination. Dr. Scott has been with us for the last 3 to 4 years. He's entertained us. He's an unbelievable speaker. He gets the highest marks of any speaker that we have. And I just would like to give him what is the Admiral Award, which we give to a person of this high caliber every year. So, Dr. Scott, we thank you.
Oh, thank you.
And
I teased about that last year.
so thank you
so
again,
much.
and please let him get a picture of you.
Oh, yeah.